You can see it clearly.
Yes, excellent. Thank you very much, everybody, especially thanks to Ibrahim to organize such a fantastic meeting. I can reassure you that this takes a lot of effort to organize meeting across the globe when you have speakers around the world, and especially with difference in times and different subspecialties together on one forum. Now, obviously, this COVID-19 pandemic has been unprecedented, as everybody knows, and it has a big death toll, which is probably directly related to the COVID, but also indirectly related to COVID. My aim today will be to have a discussion around COVID-19 and acute coronary syndrome. There are things that people are worried about, and I will try and keep this as open and interactive as possible. I think all of you, I will request that if you have any questions, we should stop at that point and discuss before we moving on to the next. There are not many slides. It will be more of a discussion together to inform the public and the healthcare professionals about what is the best possible strategy, taking into account the local policies and the safety of the patients as well as the healthcare workers. As mentioned, I'm a consultant interventional cardiologist, and my job is mainly to deal with acute coronary syndromes in the form of intervention, stents, and everything else. Can you hear me?
Yes, we can hear. Yeah, we can hear you.
Okay, so I would start with a simple slide, and I would like to keep things simple. COVID-19 and ischemic heart disease. There are two ways to look into this in a simplified way. One is the direct effect on the heart, especially ischemic heart disease, and there's an indirect effect. And I think indirect effect is equally important than the direct effect. And let's talk about the indirect effect first before we start looking at the direct effects of the COVID-19 on acute coronary syndrome. Now, this, I'm sure all of you who work in the cath labs and coronary care unit or acute cardiac admissions, they would have noticed that there is a reduction, a significant reduction in the number of patients presenting with acute coronary syndrome to the hospital. The data is coming through, but the latest information from the Spanish Interventional Cardiology team came up last week, and they have pointed out about 50% reduction in acute coronary syndrome presentation. As we have the data over the years, this time of the year, and under normal circumstances, we would have had more patients coming to the hospital. And now we are seeing the 50% reduction. And the reason being is that patients are worried and they are ignoring the symptoms, and they're trying to combat the symptoms and stay at home. It is understandable that they are worried to acquire COVID-19 infection when they go out, or especially to the hospital. But important thing to remember is that we do not have any treatment for COVID-19. It is only supportive management and the body to find time to fight the infection. While for acute coronary syndrome, heart attacks, we have definite treatment that reduces the mortality and morbidity. So the first message that we should be passing on to the public, that despite the fact that COVID-19 pandemic is there, they should not be ignoring the symptoms of heart attack, mainly chest pains. Next would be delayed presentations. People are waiting at home longer. And what happens, as you all know, that if we lose that 12 hours period or 24-hour period with ST elevation MIs, the damage is done. People will end up in heart failure. People will have arrhythmias. And we have missed the opportunity to provide them the timely treatment. Now, the whole point of ST elevation MI treatment in the form of primary PCI was to avoid complications, namely heart failure and arrhythmias. It looks like that we are going back to 20 years when patients present late in the form of heart failure and arrhythmias as they are presenting symptoms, as they have delayed contacting the healthcare professionals. So what we are seeing now, reduction in the number of patients coming to the hospital with acute coronary syndrome, but also seeing a number of patients coming through with late presentations, having complications in the form of heart failure, arrhythmias, and even cardiac arrest. This makes things even more difficult for the healthcare professionals, because the dilemma will be whether we should still continue with the medical treatment or offer them invasive investigation and treatment, especially when they are presenting in a cardiac arrest situations. As you know, that cardiac arrest, apart from VF arrest, the mortality is very high, especially if there is underlying heart failure. So to avoid these complications, we should be encouraging our patients to report chest pain as they normally do, so that we can avoid the late presentations and the complications. Also, in hospitals where you have a referral pathway from small district general hospitals to tertiary hospitals, people would try and aim and manage the low risk or intermediate risk ACS patients as medically, especially when they are old. This is not wrong. It has some evidence that supports that we should treat old people with a lot of comorbidities with medical treatment, but it should not be different from what we do on the normal day-to-day life. We should do consider COVID-19 infections and transferring the patient from DGH hospitals to tertiary hospital for intervention, but we should not deny them the opportunity of the best treatment available. As you can understand, delayed presentations, not presenting to the hospital with initial symptoms, and then presenting with cardiac arrest will have a long-lasting effect on life of the patients in the form of morbidity and mortality. And I think when we have a valid evidence-based treatment available for acute coronary syndrome, I think it's best we should encourage our patients to contact us as they always do. Any questions on this?
Mudassir, can you hear me?
Yes, I can hear you.
It's just, do you think the confusion between the symptoms of COVID-19 and the acute coronary syndrome is playing a role? Because we are encouraging people, if they have symptoms of COVID-19, to stay at home at the start when they are not very ill. So there is a lot of similarities between the symptoms, between the two problems. So how will you deal with that?
Well, it is very true. Patients with symptoms of breathlessness, especially, they can be COVID-19 presentation, or they could just have asthma, COPD, or any other infections, including heart failure. So it is a challenge. It is a challenge. I think as far as the patients are concerned, they are not in a position to differentiate between these different diagnoses. I think the hospitals and the trusts should have a system in place where they can have a quick triage of the patients for assessments, especially the patient with risk factors like diabetic patients who can present with atypical symptoms, patients who are known to have ischemic heart disease, previous bypass grafts, and heart failures, and all those things. And these are the patients who are at high risk. So if the hospital has created a way to be contacted by the patient and a quick urgent triage system, whether that is over the phone or it is popping into the outpatient clinic or into any clinics, whether they are remote in the GP surgeries or next to the ED, I think that will give them the opportunity to present to us, and we will be able to screen this. Undoubtedly, this will increase a slight risk of acquiring COVID-19, but this is about the balance between risks and benefits that you want to achieve. And I think there's no perfect solution to this. I have been contacting my patients over the phone, especially outpatients, clinics, and follow-up patients. But we have a direct line in the hospital, and people can present with chest pains, or even if they don't want to come to the hospital, they can call us and we can go through the symptoms and give them advice. And if we think that there's a suspicion that they should be coming into the hospital, I think with a small risk of acquiring COVID-19 and the benefit of being treated for a presumed or suspected MI, I think it's worth taking a risk.
Thank you very much. That's very clear. Any questions, Ahmed or Abdulazim, from the public, from the...
Nothing from my Dr. Ahmed Adlan.
Not at the moment, no. I think that's a very good point you raise about patients not recognizing their symptoms.
Yes, I think the more we inform the public, and this is social media era, and I think the more informed patients are and more trust they have in the services and more belief that they have in us, they will be contacting us to get the help. And I think all the trusts should have some way of triaging these patients quickly so that we can provide the acute care for the heart attack patients. So let's move to the next. Now, direct effects of COVID-19. Now, if we look at the literature, it is evolving. COVID-19 wasn't there before December 20 or October 2019. But we had similar viruses like severe acute respiratory syndrome COVID-2 that came in 2002 and Middle East respiratory syndrome COVID virus infections. And we do have outcomes, data, and meta-analysis available. Now, the question is whether those COVID viruses are going to behave exactly the same way as COVID-19. I don't know, and I don't think anybody knows. Only thing we know is that COVID-19 is more contagious. It is spreading more fast, and it has infected more people in the world than the other two viruses in the past. Now, we do have information available from the meta-analysis of SARS and MERS COVID viruses. And some people have extrapolated that information and evidence and using that evidence for COVID-19 because it belongs to the same family with some variation. And we expect that COVID-19 should behave similar to SARS and MERS viruses. So whatever evidence we have, it is based on the previous records. Now, when I was looking at these evidence, a lot of evidence will be observational study. There won't be any head-to-head trial. There won't be a randomized controlled trial because it is impossible to have these trials when these infections appear as pandemics, because the aim is to manage the patients, prevent the deaths, and prevent the morbidity. So whatever evidence is there is not very strong, but it is there. And we should take that evidence with caution. Now, How does it work and how does it affect the heart and the cardiovascular system? Angiotensin converting enzyme 2 has been implicated as a membrane protein that is involved in the pathogenesis and infecting the cells. Now, these enzymes are available throughout the body, but the main concentration is in the lungs, in the heart, and the vascular endothelium. And these enzymes do play a role in helping the immunity and in maintaining the cardiovascular responses. We know that ACE2 or angiotensin converting enzyme 2 is there in the heart and in the endothelium. So what it is going to do is going to cause inflammation. If there are localized inflammation, that can cause problems in the vasculature, and the vasculature anywhere in the body, including the coronary arteries. Any infections or any viral infections theoretically can cause plaque ruptures and MIs. Do you think that we have evidence or there's a way to differentiate an MI patient coming through to the cath lab or to a chronic care unit that we can differentiate whether this is related to COVID-19 or otherwise? I don't think it will be easily possible unless you have a system in place where you can analyze the plaques in detail and do a cardiac MR to look at the inflammatory processes. I think theoretically there's a risk, just like any other infection, to cause plaque rupture and MI, so as is the case with COVID-19. A couple of days ago, there's been a study published in New England Journal of 18 patients presenting with ST elevation MI, and most of them, they were COVID positive, and there was a high mortality in these patients, although they have received the required primary PCI intervention in all the cases except one when it was thrombolized. It just tells us that anybody can have a heart attack, including patients with COVID-19. Whether COVID-19 patients are higher risk of MI compared to ordinary population with the same risk factors, a study needs to be designed and assess this. But as far as the common sense prevails, I think people with COVID-19 infection, they will have higher oxygen demand, higher workload on the myocardium, higher blood flow into the coronary arteries and under inflammatory situations. And that does increase the risk of plaque rupture. So the common sense says that there will be high risk of these patients going through, but so as the case with any infection. So type B MIs have been in the textbook and we have seen them throughout our careers and they are still happening. I don't think this is any different than other type B MIs, number one, and number two, a true MI due to plaque ruptures. Now, myocarditis is another effect because inflammation throughout the body can involve the myocardium. And most of the people who have seen the intensive care patients who are intubated, ventilated with septic shocks, if we check their troponin levels, they are high, and they're very high. They are in thousands. But does that mean they had the heart attack? Honestly, no. I think that is a type BMI kind of picture, an inflammatory process. But it does have an effect because if somebody has a myocarditis in an ITU situation, it just reflects the severity of the infection in the body and the body responses. But it makes it difficult for the intensive care doctors to manage these patients once the myocardium is involved, because it will have an effect on the myocardial contractility in the shorter run, and the longer run, it will, if the patient survives, will have heart failures So it does put a risk and difficulty to intensivists to manage these patients once the myocardium is involved. The question is whether these patients who are COVID-19 positive and admitted to the intensive care, should we be checking troponins? And based on troponins, we should be looking at deciding what are the possible expected complications in the future and try and address those in advance. I don't think anybody can tell us whether we should be doing it or not, but I can reassure you it's been done throughout the world. And once you have the information with troponins, you are making decisions. You are making decisions whether we should continue to support these patients for longer periods of time on ventilations or not. So it does help somehow somewhere in the treatment strategies to decide the escalation strategies, but I don't think it helps us in terms of managing the patients because unless the heart failure develops, we are not going to give inotropes or any other medications. The third thing that came through is hypertension. So we know that angiotensin converting enzyme and would have a role in autoregulation of the cardiovascular system, especially the blood pressure. So there's been talk and mentioned that people can have uncontrolled high blood pressure in COVID-19 situation. And that could be partly because patients with who are already taking the ACE inhibitors or ARBs, they have higher expression of these receptors, and those receptors will provide a substrate for the infection. Now, the question will be whether we should be stopping all the ACE inhibitors and allowing the COVID to occupy even more of the convert ACE to enzymes. The jury is out there. Nobody can tell us whether we should be stopping the ACE inhibitors or ARBs, but clearly there has been a discussion. People have been talking about it. Patient has been contacting us and asking for advice. I think, as far as I am aware, there is no evidence in all the societies around the world, AHA, ACC, BCS, and all the European societies have said we should continue with the ACE inhibitors and ARBs as we are doing for the blood pressure control, unless further advice comes. But I have come across patients who have rang and said they will not take the ACE inhibitors. And certainly have to change it to a different medication. I'm sure some of you would have come across this in your practice as well. Any questions for now, Anas?
It's very important, the point you mentioned about the angiotensin converting enzyme. That's really, we are facing a lot of questions, and actually not questions, patients stopping their medications and coming with very high blood pressure because of the role of the social media, especially in our third world here in Sudan. Social media play a big role in the medical treatment and these things. So it's up to now, there is no evidence that we need to stop. Hello?
Yes, we can hear you.
Hello? So up to now,
I think we need to welcome Dr. Al-Sadiq Askar. Dr. Al-Sadiq, can you hear me?
So up to now, there is no evidence that we should stop medications. This is number one. I need if you can stress on that.
Can you hear me, Dr. Al-Sadiq?
It looks there is a bit of noise, Abdul Azim. Hello?
Yes.
Okay. So it's just a question, just to stress, there is no evidence to stop the antihypertensive ACE inhibitors or ARB. The next question about the mode of death in patients with COVID-19, people will speak about cytokine storm or fulminant myocarditis. should we, any trials about use of immunosuppressant in these people, especially people presenting with myocarditis?
Well, there is absolutely no evidence of any drug available in the market that one is better than others. Again, the problem is with immunosuppressants, especially if you look at the steroids, that normally helps with the inflammatory process in pericarditis and myocarditis and other situations. If we reduce the immunity by suppressing it with steroids or other drugs, we will increase the likelihood of COVID infection to be spread even more. So the balance is needed here. I think if you look at the information with regard to patients with asthma, just for example, people who are coming with asthma exacerbations to the hospitals, normally we give them nebulizers, steroids, and probably antibiotics. Since the COVID-19 pandemic came up, the advice has been to all that we should avoid giving steroids to patients with asthma, because that will suppress the immunity and make them more susceptible to a COVID-19 infection, or make it even worse. So yes, under normal situations, suppression with immunosuppressants would help to reduce the inflammatory response, and it will work. But in this situation, we have another problem, because the moment we try and support the myocardium, we will increase the infection with COVID-19. So I don't think immunosuppressant is the solution. Any other questions?
I think there was just the one point I wanted to highlight regarding the ACE2. So I think you've mentioned it, that the American College of Cardiology, the American Heart Association, the British Cardiovascular Society, and the European Society of Cardiology, they've all recommended that patients who are on ACE inhibitors and ARB inhibitors should continue unless advised to stop by a medical practitioner. And there was one study or one article published in the New England Journal of Medicine suggesting an alternative hypothesis that blocking the renin-angiotensin system in COVID-19 may potentially be beneficial in patients with lung injury. And we know evidence from previous studies that stopping ACE inhibitors in patients with heart failure, for example, does carry significant risk of harm.
Yes, absolutely right. I think there's a lot of unknown, but as far as the evidence is coming through, there is nothing that supports stopping these medications. And as you quite rightly said, it could just be more beneficial to continue with these medications for now, unless we have enough evidence to say we should change it to a different drug.
And there was one other thing regarding the troponin. And the American College of Cardiology, they've produced a statement to recommend that clinicians should only measure troponin if the diagnosis of an acute myocardial infarction is being considered on clinical grounds, rather than just routine troponin testing in all patients.
Yes, well, I've been through that paper as well, and yes, they have said it categorically that we should not order the tests which are not necessary in making decisions, or helpful in making decisions about the treatment strategies, because even if I know that myocardium is involved, what I'm going to do differently, it's just going to raise the worry and concern that it is affecting. And I have come across through my career that patients on ITU with septic shock had troponins of 20,000, and when you do the echocardiogram, it's reassuringly normal, and they come out after a week, which I expect that will be the case in most of the COVID-19 patients as well. I think there may be a role of echocardiogram in patients who are not doing well on ventilators, especially with hypertension, that if we do an echocardiogram on these patients, then we will have the information about the cardiac contractility and support. And that in turn will help us to decide whether we will consider inotropic support for these patients or not. Because if it is a combination of septic shock as well as cardiogenic shock, then the likelihood of survival is very small. And then it will also help us to make a decision about how far we're going to push with our patients, especially if they have underlying comorbidities.
Okay.
All right. So next, let's come to our day-to-day work, how to manage heart attack patients. Now, every single hospital and every single cardiovascular society or interventional society in the world would have issued their guidelines with regard to how we manage patients with heart attacks. I have kept it simple. Primary PCI, medical treatment, and thrombolysis. And primary PCI, as far as the evidence is concerned, it is still by far the most superior option available for patients. And the reason is patient can come in, have a treatment done, if uncomplicated, can get home the next day. All right? So the stay in the hospital is short. They have the best treatment available, and they are out of the hospital as quickly as we can possibly imagine. Yes, the question is whether when we are doing primary PCIs, whether we should continue is as routine we are doing it, or we should alter our strategies. Personally, in our trust, and as far as I can see from the British Cardiovascular Intervention Society, the guidelines have been very clear that primary PCI still is the best option available for patients with acute myocardial infarction. So I would encourage people to still continue to provide the acute care for the patients that we have always done, because that's the best treatment with the least risk and least chances of acquiring COVID because of a shorter stay in the hospital. Now, medical treatment is definitely an option, and especially it is an option for patients who are presenting late or patients with end-STEMI and a lot of comorbidities. For example, if they are presenting a week after the symptoms with troponin of 5,000 and they have previous grafts, I would say we should treat them medically in first place, optimize their treatment, antiplatelets, statins, and everything else, and discharge them and have a review in a week's time over the phone and assess them whether they would need further treatment or change in their treatment strategies. If they are stable in old age group with a lot of comorbidities, I think if they survive the acute event, they are most likely to survive the following few weeks to months or years without any major complications. But there should be a robust way of assessing them in a week's time once they are discharged from the hospital. Thrombolysis, yes, it is available. And we have got few vials now collected and stored in the fridge that in case we will need them. Technically, we have used thrombolysis only if we cannot provide the primary PCI within 2 hours of touching the healthcare professionals. Now, I have come across thrombolysis in the last few years, especially when a patient is being transferred from a far area where there is no health service. But I do not see many situations where I would be using thrombolysis. One situation that I can think of is when patients are COVID positive or intensive care, intubated, ventilated, and they develop ST elevation on the unit. Then yes, we could talk about thrombolysis in those situations to give them the time. But we know that about 50-60% of the patients after the thrombolysis will not achieve the target changes in the ST elevation, and they still will end up under in the cath lab for intervention. Now, on a different note, I need to mention this, and I've come across this in the past as well, and I'm sure as we are all doing primary PCIs, the knowledge of thrombolysis, how to administer the thrombolytic agents, and the experience is not there anymore, because I know that most of the staff on my CCU, they have not thrombolized the patient ever. So training them, giving them the experience and support during the working hours or out of hours, it will be a big challenge as well. And we don't want to be wrong here, because once you have given the thrombolysis, then the risk of bleeding is pretty higher if we haven't ticked all the boxes appropriately. So in terms of training, we need to look at carefully if we want to provide this service of thrombolysis to the patients over primary PCI. We should make sure that we have enough support training available for the staff to be considering these patients for thrombolysis. And I would strongly suggest that it should be a decision of a consultant cardiologist. Whether they are in the hospital or out of the hospital, they should be contacted, discussed, and agreed for consideration of thrombolysis. I still don't think that is the best, but I think there is possibly one or two situations where you could consider thrombolysis. Now, I am also aware as a cath lab lead in Sunderland Royal that there's been a lot of talk about how we provide protection gear to the staff, especially when they are coming in the middle of the night for primary PCI. Obviously, the guidelines have evolved, and at the moment, anybody who is coming as primary PCI to the cath lab, whether they have COVID-19 symptoms or not, we will consider them as COVID suspected or COVID positive patients, and we will use all the personal protections available. And the reason is that all patients with ST elevations MI, they have a potential of cardiac arrest, requiring shock treatment or brief CPRs during the intervention. And if we ever get in this situation where patient has a cardiac arrest in the cath lab, that will definitely be an aerosol generating procedure. And I think we will not be protected if we do not have adequate personal protection available and ready. So what we have done here in Sunderland, that all patients coming for primary PCI, whether they are stable or in a cardiac arrest situation, where definitely there is aerosol generation, we will be providing all the personal protection to all the staff, mainly the PCI operator and the scrub nurse, and a nurse who is also available in the lab in case we need to do cardioversion or shock treatment following a cardiac arrest. So it is very, very important for all of us to recognize this, that as we are there to save lives, it is our moral, ethical, and legal duty to look after ourselves and our staff and make sure that this valuable staff is well looked after. Because if they are there, they can continue to provide the service and continue to save lives. So my take on personal protection in primary PCI is all or none. We will go for full personal protection for all primary PCI patients. Because if we don't do that, and if we expose the infection to our staff, then we will lose our valuable on-call team and the operator who are providing excellent service. Any questions on these?
Yeah, Mudassir is just about, we know that there is a lot of cases of myocarditis coming with the COVID-19. And a lot of time it's difficult to differentiate it from real MI. So are you taking, from your experience, say in the last 2 weeks, for example, whatever cases you did for an MI in the cath lab and you find them with normal coronaries and tend to be myocarditis rather than acute coronary syndrome, is it a big percentage that we should rethink about using other modalities like CT, for example, CT coronary angiography, instead of getting into the cath lab and exposing all the stuff there and exposing the patients to high risk, for example?
Well, it's a very good question. I think in our setup, we have a small DGH and our primary PCI numbers are not huge, but we haven't seen many myocarditis patients coming through. Mostly the patients that have come through over the last few weeks, they are mainly cardiac arrest patients. And they are possibly the late presenters. And when we have gone in, whether either we have found a single culprit vessel or multi-vessel disease in these patients. So we have, on our personal experience, mostly the patients coming through are genuine coronary artery disease patients. Yes, every now and then we will have one myocarditis patient with some dodgy ECGs and not very clear. I think still the best way is to take them to the lab because there's no other way of knowing whether this is a true ST elevation with the normal epicardial arteries or not. CT scan is an option, but the problem is out of our CT scan service is not available in our trust, and I don't think there's any evidence that we should be using CT coronary angiographies for acute MI cases. I can understand that patients who are young, fit, otherwise well, with some abnormalities on the ECGs, you're not sure whether this is something that we should take to the lab or not. Yes, that is the case where we can take them for a CT angiogram. But unfortunately, in our trust, we have only 1 day available for the CT angiogram, and there are no out-of-hour services available for CT angiogram. So I don't think that is technically a valid option. Yes, thrombolysis in these situations, as I said before, in patients which are borderline ECGs, otherwise well, no other comorbidities, thrombolizing them would be unfair, and it will still be safer to take them to the lab and do an angiogram in 10 minutes and have a clear answer. Any other questions? Any other questions from anybody?
Yes, I would like to welcome Dr. Muhannad and Dr. Al-Sadiq Askar. Dr. Muhannad and Dr. Al-Sadiq, if you had any comment or any question, you can.
Ahmed Abdul-Azim.
Okay.
Yes.
This is Sadiq Askar.
Can you hear me?
Yes, we can hear you. We can't see you.
Right. Okay. Let me just see if I.
Okay.
I can see you on my screen.
Can you see me now? Can you see me?
No.
Hello. This is Sadiq Askar from Khartoum. I can see very well. Next to
Go ahead, ask the question.
No, it wasn't a question. I was just going to make a comment about what I've just joined a little late. However, I just endorse what's been said. The only reason we stopped taking patients to the cath lab with primary angioplasty is because of the fear of contamination and getting infected with COVID or with coronavirus. And the best way to combat this is by having a full personal protection equipment. Once you've done that for yourself and the whole team, then it's not a problem. Thrombolysis has been put forward as an option, but of course you have to think about the efficacy of thrombolysis, which is not 100%. And what happens if you give the thrombolysis and the ECG does not resolve? Then you're going to have to go in a much more messy situation, a much more difficult situation. I think the best strategy is still to go for primary angioplasty if you suspect this is acute MI. And of course, with the ST elevation, this is mostly the case. Now, there are some exceptions, probably if somebody is in advanced stage of corona or COVID disease and they are on ventilator and their oxygenation is not that great, then maybe you could think about, okay, we can go for conservative management. And echo here could be very helpful to tell you whether you need to go for direct primary angioplasty or use just conservative treatment. And we have seen this few times, not too many, where we decided that somebody has been intubated for 6 days because of COVID, and they do have ST elevation, but this is global ST elevation, which tells you in a way this is probably myocarditis. But the primary approach is still primary angioplasty.
Yes, thank you, Mohammed. I agree, and as I mentioned in the my talk, that personal protection is a key here for patients coming through the cath lab 3 o'clock in the morning. All the staff relevant to the cath lab will have all protection available, and also after the procedure, I think the cath lab needs a thorough clean as per the infection control guidelines before we bring another patient in. Fortunately, most of the places will have more than one cath labs. So in case we have a series of primaries coming through, we can switch from one lab to another lab. I'm sure you will have a similar experience.
Yes, indeed. We have a clean lab where this is for Dunning, and we have the lab that we're using for all the patients that's coming through nowadays, which is considered as the dirty lab, if you like. And yes, it does get clean between cases, and it does get well looked after.
Excellent. So I think I'm on my last slide, and I think this is a general slide, and the aim is to encourage our patients to report the symptoms of chest pains and heart attack symptoms and not ignore them. And the trust should have a protocol in place to provide rapid triage of these patients to decide whether we need to bring these patients in to the hospital to provide the standard ACS treatment and care, which does have, which is available throughout the country. And I think given that COVID-19 is only a supportive treatment, unless we end up in intensive care, we should not deny a well-recognized evidence-based treatment for acute coronary syndrome and angioplasty to our patients. Obviously, every single hospital will have their policy reviewed for primary PCR and thrombolysis. And as mentioned in discussion, that primary PCR is still the best option available for all these patients. And last but not the least, I cannot stress more that all the healthcare workers, they are important and they should have all the adequate personal protection available. And they should always ask for protection equipment. If they are not provided the protection equipment, I think there will be an escalation policy available in every cath lab and every department, and they should follow the protocol and escalate to another level if they are not happy with the protection equipment available to them. Any questions or comments, please?
Thank you very much, Dr. Mudassir, for the very clear messages that in this dilemma guide us to the right management of this patient with acute coronary syndrome, that we should give them all the available evidence-based medicines for COVID patient with acute coronary syndrome. We are seeing cases here in Sudan of myocarditis, and I think the storm is like starting in Sudan now. We are seeing more cases and more cases of COVID-19. Today, they declared the biggest number. So we are expecting to start to see these patients with an acute coronary syndrome and COVID-19 at the same time. The only thing available for us here, even before this disaster, is primary BCI in very few hospitals, but mostly thrombolysis for these patients. Final message about any experience, any data came out for patients with COVID-19 receiving thrombolysis or not?
Well, to my knowledge, there is no evidence or data available. The only data that is coming through, and I mentioned that there was a paper of 18 patients undergoing primary PCI and one thrombolysis, and it's been published in New England Journal last week. And I think still most of the places in the world, they are still taking primary PCI as the first thing if it's available. Obviously, in places like Sudan and other part of the country, other part of the world, the new data will evolve in the meantime, and it will be available. But at the moment, as far as I can see, there is no data available on thrombolysis.
Because there is some evidence. There is some evidence that about coagulopathy in these patients. So we're expecting to see some encouraging data, or we're hoping to see some encouraging data about thrombolysis in these patients, even to help their lungs, not only their heart. Thank you very much for the nice talk.
Thank you.
Just a quick question, Dr. Baig. Hello?
Yes.
Assalamu alaikum. This is Abu Bakr Khalil from Ireland.
Yes.
Are you seeing many patients with significant ST elevation, like almost 10 millimeters, and when they arrive, they have normal coronaries, and it keeps on happening on the same admission? Are you seeing those type of patients?
Well, certainly in our trust in last few weeks, we haven't seen any of those plumed ST elevations without coronary artery disease. I think maybe it suggests a coronary artery spasm or severe myocarditis picture, but these changes will be widespread across the chest leads and the limb leads. Certainly, we haven't come across such an ECG with a normal coronary arteries.
Sure. We had one particular patient last week, a young 52-year-old who came in with initial chest pain and clear-cut chest elevation inferiorly. So you put your money on an RCA occlusion, and a few minutes later the patient didn't arrive, and after maybe half an hour, 40 minutes, we started to inquire what's going on. Apparently, the patient had an out-of-hospital cardiac arrest, and then he was brought into resus, and then he was resuscitated, and ROSC was achieved. So we still took him to the lab, but the ECG, interestingly, at that time was entirely normal. So we did an angiogram, entirely normal angiogram. He went down to ICU. He was intubated, obviously. Within his ICU admission, he had impressive ST elevation, only inferiorly. And I was wondering, is it a spasm? Obviously, he wasn't on any calcium channel blockers at that time, and he kept on arresting immediately after it. So this was very interesting to see this. And then he ended up having, once we started him on calcium channel blockers, he seemed to have settled completely. Having said that, he had no regional wall motion changes. He did have a significant troponin rise, and obviously we treated him as an ACS. So they're quite rare. Now, interestingly, his COVID was negative twice. And it's very, I don't know, are we assured by these tests or not?
Well, the test sensitivity in our hospitals is 60%. Okay. So I've been tested for the symptoms because I was working with the COVID ward patients and I had pyrexia and all that. So I got tested and the result came negative. And I spoke to my occupational health team and I said, look, you tell me, is it really, really negative? And the answer was the sensitivity is 60%. And if you still have the symptoms, we will class you as test negative, but COVID symptoms. I've also come across a lot of patients, and I think Ibrahim has come across half a dozen patients in one night, that those patients were COVID negative 2 days before, and then suddenly started deteriorating with X-ray changes. And then we repeated the test. They were all COVID positive. So I think it is difficult to use the test, which is 60% sensitivity, to come up with a diagnosis. In a normal cardiology world, you will never use such a test for your patients.
Can I just make a comment here about this? Can you hear me?
Yes. Yeah.
Well, it is a PCR test. It is valid at the point of testing. Whenever you have the test that's valid at that point, the next day is completely different. So if you don't pick it up the first day, that doesn't mean it's going to be negative all the time, because it's a swab and a PCR test. The only test that's going to be more sensitive and more specific is a blood test with IgM or IgG, which is still not a very easily accessible or reliable yet. So the PCR, the swab test we do is only valid when you do it, and that's it.
Can I just, sorry, Dr. Baig, I'm sorry for interruption. Can I ask you all, those who is not speaking, just make your microphone just mute? And we're just a little bit running behind the time. And can we just try to, in 1 minute, just to close the acute coronary syndrome session and then move on to Dr. Muhannad to introduce Dr. Ahmed Adlan for the second talk. Sorry, go ahead, Dr. Muhannad.
Yes, I just kind of say, which is really a comment about all this. Common things being common, coronary artery disease is still the main reason why we see chest pain and why we see ST elevation. Of course, we have to deal with the current problem of COVID disease and coronavirus differently, so we have to keep it in mind. To my mind, the most important thing to do is to keep yourself and your team protected with personal protection equipment, and to treat patients to the best of your ability with taking them to the lab if they need to, and not to change your practice as long as you're protected. That's the most important thing.
Yes, I think there will be absolutely no disagreement on your statement, Muhannad.
Thank you very much, Dr. Baig.
Thank you.
Thank you for your time, and we really appreciate it. And now, Dr. Muhannad.